So, this nice young man comes to me and he really makes his point smiling at me. He's a talented painter. I saw some of his drawings, and I can say he's got a bright future ahead. But of course, he needs a beautiful smile to make it through. His x-rays show us he's got a missing lateral upper incisor and a dysplastic one. The lateral x-ray tells us about some proclined upper central incisor and some retrognathia, which is kind of useful when dealing with conditions like this one. The intruder immediately appears while taking occlusal photographs, and suddenly it becomes clear that the upper bicuspids have rotated and taken the space of the lateral incisors. On top of that, they're also experiencing a scissor bite, while the teeth in the lower jaw appear to be very crowded. I am planning to get 12 back in arch with a coil spring and a metallic ligature, while preserving second class on the left and achieving first class on the right side. I will achieve that by using second class early elastics. I can't place a bracket on 14 or 24, so I opt for a force pair with stops mesial to the fifths in order to prevent them from sliding forward, which could delay the derotation. After 4 months, happy with the situation, I prescribe second class early elastics on the right side. Yes, the midline has shifted, but I can easily get it back in the right place. At least I hope so. The persistence of the scissor bite in the second quadrant forces me to prescribe an elastic going from vestibular 24 to lingual 33 and 34. Too bad the patient decided to not wear them. And he's clear about that. He's not gonna do it. So what? We have to get the midline back in place and give a good intercuspidation to this artist on both sides. Turns out, extraction of 12 was the best solution from the beginning, mainly because I could easily get a second-class therapeutic occlusion on both sides. In this way, we will also get the chance to lose some torque on those central upper incisors by applying a power chain on a 14 by 25 NiTi arch wire. Correcting the scissor bite on the right side was a bit trickier, but that's what I did. I used some blue resin to get temporary disocclusion on 24. I placed a lace back on the second quadrant to avoid vestibularization due to arch expansion. I placed an excessive wire between 35 and 31. And I locked everything up with one stop mesial to 35 and one distal to 31. I then waited for the spring effect to show up. Thank God, things went well as I went on with the arch wire sequence. Intercuspidation allowed me to get back to simpler mechanics on the left side, as it was creating enough retention to keep the occlusion stable. As the extraction space of 12 was hard to die, I used some combined power chain mechanics, binding 2, then 4, and eventually 12 teeth with different power chains in order to close every single space at once. At a year from the beginning, the patient was sick of me and begged for freedom. As the results weren't bad, I just asked him to be patient for a couple more months, just enough to consolidate the new arch form. I also made a first-order bend on tooth 24 to increase intercuspidation. You can do that without changing wire, directly on a NiTi with a hoof reedy bend-back plier. After 14 months, I pulled off the brackets and polished the teeth. Knowing I could have done much better, I think this case has been extremely useful to me because I learned to adjust my strategies to a non-compliance patient. Well, he got back to his paintings. And the day after, as I watched his medical history, I thought to myself that every step ahead we take in dealing with unexpected problems is certainly a win-win situation, both for us and our patients. I won't hide I felt quite relieved while putting away his medical history.